So I hope my screen is visible to everyone. Just say yes. Then only when you can proceed it. Not visible. How is it possible? It's not visible. My testing screen is showing yes. It's visible. And stop raising the hands for every question. Answer yes or no. Otherwise, unmute yourself and answer. Raising hands was all the time like single answer. This is not the professional behavior. I'm warning every one of you. If you are studying, be very serious. Otherwise, there is no use of studying. Taking out my time for not just you guys. It has a lot of other things also. I hope you all will consider this sincerity. Yeah. So we are here to learn about headache today. So, like all of us, we understand what is headache. Headache in general, headache is the pain in the head, no doubt, and it's very common kind of condition which arises from psychological or any kind of eye issue or any kind of systemic issue, including fever, including any kind of weakness, post traumatic, anything. Okay, or most importantly you will find is what is tension type headache. So every second person you will see saying you it's having a tension type headache, right? So that is the most, I can say, the headache is the number one pain in the world. What is the second one? Can anyone answer in your message? I'll see that. Or unmute yourself and answer. What is the second most occurring pain in the world after headache? No answer? It's a back pain. Back pain, which is the number two. What is number three? What is number four? You guys, your stomach. Well, nice. What is it? Number four? Number four is a real challenge. Nobody remembers up to number four, right? It's hardly one, two, chest. I think you're guessing. You're not saying. It's a teeth. Toothache is the fourth largest pain in the world in general. Okay. Anyway, that was the something different. So, how do you define headache? If it is a science, suppose they ask you 5 marks question, how do you define headache? So, you'll be defining it's a pain or unpleasant sensation or discomfort. Check out the word discomfort between the orbits. Okay, between the orbits or occiput, arising out of pain sensitive areas. Okay, this I mugged up when I was in my final year. Okay, pain sensitive areas. Okay, so pain sensitive areas, what is meant by pain sensitive areas? Can anybody tell me? When I speak about pain sensitive areas, what does that mean really? Anyone has any idea about pain sensitive areas, what it could be? Obviously I'll tell you, but just let me know if you can. I'll be very happy learning that you actually, you know about it. Anyone? Pen sensitive area. Okay, no problem. As I'll explain, don't worry. So, pain sensitive areas, you have to choose either it could be intracranial or it could be extracranial, right? Either it could be intracranial or it could be extracranial. What is intracranial and what is extracranial? You understand very well, right? I should not explain that. I have explained these things in proper detail earlier. Okay, so say for example, you want to remember the intracranial. I would say that there are methods to remember, like what is the pen sensitive area. Basically, areas, pen sensitive areas. So as I said you, it could be intracranial as well as extracranial. You will say intracranial means from inside the, like a brain. It's not like that. Intracranial pen sensitive areas are mostly, just remember, it is like it is based on fossa. I mean, interior, middle and posterior fossa. But intracranial areas you can remember like a sinuses. What kind of sinuses I'm talking about? Venous sinuses, right? You would have heard of venous sinuses. Okay, then anything else? Basal arteries. These all are pain sensitive areas intracranially. Okay, then you have cortical veins or inside areas. Okay, then you have dura mater. Okay, dura mater. So dura mater of, or you can say like a dura of anterior, middle and posterior fossa of the brain. Cool. So, like, pain usually referred to either the front part of the head or maybe the temporal, the side part of the head, right? These regions, it could be either, like a one-sided, what you say is ipsilateral, okay, or it could be bilateral. But you should always write in your examination after the headache definition. What I said you here is definition, okay. After the definition, what you can go for, you can write in the pen sensitive areas. Please divide like this, what I have done, okay. This will get you better marks, because always remember, whenever you are writing in your examination, don't write in paragraphs much. It should be inside the points, or it should be like a diagrammatic. Okay, it's easy for examiners to check out your examination paper. Okay, what about extracranial areas? Can anyone name only two areas, at least two areas? Okay, good. Muscles, but can you name one muscle, one large muscle? Okay, vessels. Okay, vessels in scalp. Scalp, Okay, good. Anything else? Nasal areas, nasal, or you can say paranasal areas. Huh. Mucosal. If I write mucosal also okay. Otherwise, mucosal membrane usually has headache here, right? I mean, it causes headache. Otherwise, ear, teeth, gums. If any one of you have experienced the teeth pain or ear pain or even the gum issues, you would have had, like a back pain. Sorry, the headache also. Okay, so this is the normal general definition, and how it is, like a pen sensitive areas. Whenever you are writing this particular thing in your examination. It gives you a very good sense. And then obviously the intracranial and then extracranial. Okay, cool, very simple. Now we will go for our see the next page. Just 1 minute. So, like, now we have to see what is the classification of headache. Do you have any idea about the classification of headache? Any one of you? I mean, different type of headache we will come one by one, but classification of headache. Anyone has any idea? Yes, you can tell me. No problem. Looks like you have studied from brands. I mean, I'm not talking brand. I'm talking about the book. Okay, classification of headache. Okay, so as per the International Classification of Headache of 1988, okay, the book says that there are different type of headache. Okay, different type of headache, and it has given even the percentage also. What kind of percentage I'm talking about? Occurrence. Okay, the most, I'm just making one types of headache so that you can remember easily. The most, as per the occurrence they have divided, the most occurrence headache is the tension type headache, and it accounts for nearly 45% as per the practice they say. Okay, then the most important headache is the migraine. Have you heard of migraine? We'll study today anyway. Okay, then after that it comes the number, the eyes sinusage kind of diseases. Less than, I think, almost 8%, you could say. Okay, then you have a infection, normal infection. If you would have experienced the normal infection, like, say for example, diarrhea, or maybe the dengue or anything, then you would have seen, like, patient complaints of the headache, right? So I would say that systemic infection. I hope everyone is able to see my screen. It's about 7 to 8%. Okay, 7%. Then we have trauma. Yes, head injury. That's what I'm saying you. Trauma. So trauma itself account for 3%. Okay, no, I'm not saying all the time head injury will be of that severe category. See, the question is, like, do we consider, it's a very good question, do we consider the trauma of only the, like, heavier kind of head injury, or what are we going to consider? Okay, and no, we are not going to consider any of these things. We are going to consider all types of trauma. It could be even the like, subdural hematoma. It could be head injury due to RTA. Okay, it could be all sort of like, trauma which has like, which has some effect on the head. Okay, so 3%. Then after this trauma, anybody can tell? Drugs. Okay, so this also 2%. Okay, anything else anybody can tell? What I have written? CVS, cerebrovascular disease. Okay, so CVS diseases, cerebrovascular system disease, this also cause obviously, and it accounts, but these all are, like, less, less than 1%. All this. Okay. Other intracranial disorders? Other intracranial disorders. This also accounts for less than 1%. Okay. And after that, metabolic disease. Metabolic disease also less, but it is actually cause the headache. Metabolic disease. This is also less than 1%. Okay. Yeah, one or two is there like neuralgia. Have you heard of neuralgia? Neuralgia. This also less than 1%. Okay, one more is there. We will study anyway separately. Cluster headache. Have you seen any kind of patient of cluster headache? Any one of you till now? Okay, this is the types of headache I have generalized in a picture so that you can understand it better. Akansha, you have any question? Okay, no problem. Let me know. So, just 1 minute. I'll see the condition of how it is happening. Yeah, it's happening. Well, thank you. So, okay. So, this was the classification of headache. Cool. Yes. So, I understand your question. Cluster headache we are going to study in a separate uh, head. Okay. Yeah, separate head. Don't worry. We'll come on cluster headache. We'll come on migraine. We'll come on tension type headache. Don't you worry. Okay. So now it comes the like how are you going to have just 1 minute, I'll check the black. So how are you going to have a proper diagnosis? So what is your I would say that you should write the what is your diagnostic approach for the headache? Yes, correct. You should have proper history. You should have nice. I am happy that you guys are following this very well. Thank you. So you can have clinical history, and then you should have examination. Good. I really liked it. History and examination. So history. What all things are you going to sum up? Anyone? Yes, wonderful. History. History, we are going to see what is sight. Wonderful. Anything else? Yes, precipitating factor. Too happy for you. Anyone else? Anything? Other symptom. Onset. Very good. Nice. Wonderful. You have to ask always either it's the first one or previous attack. Wonderful. I'm happy for you. Okay. Anything else? Either it's a acute or chronic. Wonderful. In onset, what all things can be there? Those who answered onset, acute or tell me here not a chronic. It's not a chronic. No, some other student answered me onset, so I'm asking either it could be acute or it could be gradual. Acha, how it is gradual? Like few people they have like in coming days or in the week, they'll have pain. So that we say as a gradual kind of presentation. Okay, so that's where the gradual happen. Okay, good. I'm happy. So this is how you have to take history. But how are you going to exam? Because examination is really tough. It's a general condition where like it involves multi-system. So how are you going to make it very simple? Anyone has any idea? Ah, okay, that's one way. Anything else? Okay. No, examination has to be done by you. So you remember I was telling you always full general examination. You have to see all through that, very easy. Okay, so general examination, then anything else, anything specific, go to directly to the which kind of thing it has caused. Okay, so like I mean to say, if it is an intracranial, you remember like I just told you, like pen sensitive areas, right? So it could be either intracranial or it could be extracranial, right? So just point out. So considering that, it could be ocular, eye related, yes. So it could be trees related, it could be, what you have to do, you can do sinuses like maxillary sinus examination, maxillary, or basically frontal sinus. How will you do that? There is a method of percussion, right? That's how you can. Okay, yeah, scalp, really good. And then obviously you have to do the full neurological examination. I mean to say for example, somebody has, I would go for a neurological symptoms like I mean neurological examination, like say for example somebody has a multiple sclerosis. So and he or she is complaining you pain. So won't you think that after general, after general after the general examination, one is going for the pen sensitive areas examination. Okay, and at last is very important is what patient has come with the neurological condition. Clear? Is it clear? Don't ask me so tough questions right now. We are going to see in one by one chapter when it comes. Okay, okay. No, like technology is that like everyone can't see your question. So, so sometimes it is better that I only see the question. Okay, anyway, I'll tell everyone. See, the question is: do all neurological diseases necessarily to have headache? Since it is one of the most common symptoms, my answer is no. And this is very like subjective talk. We can have a lot of subjective discussion, because suppose somebody has Parkinsonism, okay, or somebody like in stroke, there is something called thalamic pain. Have you heard of thalamic pain? Oh, sorry, I really forgot to tell you. Okay, fine. uh, have you heard of thalamic pain, any one of you? So all stroke patients don't get thalamic pain. Okay, so when we were talking about, today is the chapter of pain, headache, like which is the most common pain, and which is the having the second rank, third rank, third rank, fourth rank, I mean, everything, right? So today I would like to ask you one question. If you don't know, you have to come with the answer tomorrow or day after, whenever we are meeting. Which is world's second most excruciating pain? First is thalamic, right? What is the second one? Acha, what is thalamic pain? Fine. I think we'll come on this issue later. Okay. Otherwise, uh, this answer is good. Thalamic pain is pain in thalamus. Okay. We'll discuss this later. Rather, talking now. We okay. Okay. So now I would say that as per your examination in history, you could divide the like in your diagnostic approach, headache cause wise. Okay, I meant to say that like these categories, like in general, like when it happened and how long it is. So definitely there will be three categories, right? So one is acute, then you have subacute. Just for your information I'm giving you, it's going to work for you. Okay, and then you have chronic, obviously. Okay, let us see in acute what could be the cause, what is cause in the subacute, and what is cause in the chronic. Okay, acute. Tell anyone, you can tell me, you're always free. Sinusitis. Okay, what is sinusitis? Anyone can tell me? Yes, good. So normally cold, nasal discharge, all these things. So suppose we are talking about like a diagnosis. Okay, diagnostic approach. So how are we going to, like, what are we going to do with this? Okay, fine, I'll come later. Anything else can happen in acute? Migraine. Yes, yes, answer. I'm writing, which is very very important. Cluster headache. Okay, anything else can happen in acute one? Well, very nice. Traumatic. So I'm writing post traumatic. ठीक है और कुछ? Then it could be drugs or toxic element. I mean the toxins. This can cause blood loss. Very nice. Hemorrhage. Okay. Yes, wonderful. Infection. It's, you guys are commendable that after doing whole day classes and duty, you come and you really put your brain here. That's really good. Infection, like any infection, you can tell me which infection it can be. Have you heard of brain water fever, meningitis, Japanese encephalitis, or encephalitis in general, let us say? Yes, all those things. Very good. Then it could be hydrocephalus. Have you seen any case of hydrocephalus till now? No. Okay, no problem. You will see that. Okay, yes, very nice. Happy for you. So let us come, like, what can we do for these things? Okay, I mean, obviously for sinusitis, what can we do in diagnostic way? To the most, we can take one X-ray. Okay, everything is not possible for cluster headache, migraine, and all. It's not generally possible. Recurrent attacks are also there. Then post-traumatic. What can we do? X-ray, CT. Uh, Look, Shahid, X-ray, CT, EEG, and a lot of other investigative parts we will come little later. Okay, let us finish the disease part. I will definitely teach you for like a 5 hours class on the investigation alone. Okay, it is very very important, and all the time they ask you the question like EEG, they ask some question on CT, they ask few questions on MRI. Okay, so I have to teach that, but I wanted to start for general conditions first. Okay, yes, I'll teach you, don't worry about it. Okay, hemorrhage, again you can have CT. There is something called lumbar puncture. Okay, which level lumbar puncture is done and for what it is done, I have already taught. Okay, hydrocephalus, CT, correct? So all these things. Okay, subacute. Any subacute conditions you tell me? Anyone? It can be again infection. Okay, same infection will convert into subacute, like chronic meningitis or even that TB, brain TB. Okay, or cerebral abscess. Cerebral abscess again a very important question. So we have to anyway study. I just reminded you. Yes, wonderful. Tumor, very nice. Very nice. So we will write it intracranial tumor. Okay? Yes, wonderful. Intracranial tumor. Okay. Subdural hematoma. Very important 5 marks question. Again, hydrocephalus, definitely. So most of the conditions from acute it may. Well, when it is tumor intracranial, it could be even the benign tumor also. Yes. Anything else? Intracranial hypertension. I hope in general medicine you would have studied about in detail. You have any question, you can always ask me. Okay. Then there is, as I told you, like there is always a vessel's disease. So temporal arteritis, right? So all these things. So what are you going to do? The kind of investigation for that, and how could you confirm? As you know, like infection, this time you have to go for lumbar puncture, CT, subacute condition, right? Again, intracranial tumor. What is the best part to do? Intracranial tumor. Anybody? CT. Okay. Intracranial, hydrocephalus again. What is the best part to do? CT. Wonderful. Intracranial hypertension. CSF monitoring. Okay. Okay. Is there any infection? What are you going to do? ESR, then biopsy. Few of you have studied even cardio from me. So I think they'll be knowing little more about the investigation. So, but neurological investigation we'll see separately. Okay, fine. Tell me about the chronic condition where the headache could have been. First is our tension type headache. Never ever forget to write in the type tension type headache. It's very important. Okay. Another type was ocular, right? So basically, it is straining the eye. Okay, ocular cause. Then you have obviously the drugs. Tell me anything else. Have you heard of cervicogenic headache? Anybody? It is due to involvement of cervical vertebra. Wonderful. Cervical vertebra. Even the cervical spondylosis can give this condition. Okay. So what are you going to do with that? Suppose cervicogenic headache is there. What are you going to do the confirmation part? First thing, first and foremost, what are you going to do? X-ray. Wonderful. आई का प्रॉब्लम हुआ तो क्या करेंगे? आई टेस्टिंग लाइक refractive errors need to check. Okay. Yes. But one more thing is there, very important condition I forgot to mention. I don't know how did I forget. There is something called glaucoma. This can give the acute condition, glaucoma. So glaucoma को confirm करने के लिए what are you going to do? Again, eye testing, ophthalmology has to do something in general. Okay. So I hope you just study everything systematically. It's not a tough science. It needs what it needs. It needs your attention. It needs your regularity, sincerity. So, you know, headache in the grown-up people is normally, like they're like retrobulbar neuritis or glaucoma, as I said, or any kind of cervical spondylosis or cervicogenic headache. All these can be there most of the time in adults. Otherwise, most of the headache, it is available even in the, it is found, it can happen even in the children. Okay, but common type of headache in the children, anybody can tell me? I'll be very happy if you tell. You would have studied in second year, I believe, pharmacology. No. So in children, you understood, no? In adult, what could be the most like headache? Mostly arise from the retrobulbar neuritis or temporal arteritis, or like a kind of glaucoma, all this. But these things cannot happen in children. But children will be mostly with the headache will be due to the infection or febrile illness. We say, remember pharmacology? Yeah, febrile illness, or it could be the most of the sign, most of the time sinus or nasal infection. I'm talking about the common cause. It is not limited up to what I'm saying you right now, but most of the time commonly we have found this. Okay. No, not at all, not at all. See, the question is like, can always the child be like, we say as an infection or something like that? No, not like that. I'm not saying that you take it very lightly, you don't examine. No, not like that. It could be even the underlying disease. We never know. We never know. So it could be, encephalitis, any kind of what we say abscess, or it could be meningitis. Meningitis very common in children. I've seen. It's very very difficult to treat. It's a long treatment, and uh, child has high fever. Anyway, we are going to study meningism also. So one more thing I'll tell you. Any kind of headache, especially in the child, or even in the adult also, I would say, but mostly in the child, if you find, just 1 minute, if you find neck stiffness, neck stiffness, catch every word what I'm saying you, neck stiffness, if you find any kind of headache, don't take it lightly. It needs urgent admission for investigation. ठीक है, urgent investigations, it is needed. Okay, neck stiffness के बाद कोई भी headache, you can never take it lightly. It could be the symptom of any seriousness. Okay, so in headache you have to see this thing also, urgent investigations. Okay. Yes, yes, definitely. Tumor also can cause headache in child, but not as much as like adult. Obviously, not as much as adult. So most of the time, the pineal region, you can say pineal region, and some of the blastomas, maybe medulloblastoma. Okay, so all these are definitely the cause of pain in the child, no doubt. In headache, it manifests as headache. Okay, yeah, somebody is saying hydrocephalus, obviously 100%. So if you like divide hydrocephalus in classification wise, so most of the time obstructive type, it causes headache, definitely. Yes. Okay, so what, when do you think like you need to take it very serious for children? I mean, you have to go for investigation, like apart from naked stiffness, what are you going to when are you going to see, like for CT? If the headache is acute, okay, you want me to write? Okay, fine. If headache is acute, okay, you are not able to explain why. Severity is rising. It's not rises, like with time, and you know, it is creating problem for other activities. Head size increases, especially the head circumference. You feel that in any child it is increasing. Okay, less than 5 years age, or it is like giving some different kind of behavior in child, uh, different behavior in school, different behavior at home. So just 1 minute, 1 minute, 1 minute, 1 minute, just 1 minute. Okay, so different behaviors. So these kind of things you cannot take it light, you have to take it serious. So you know till now we understood the general type of headache, general principles. you know Now one by one we will see all these headache, like some particular type of headache, one by one. Okay, so now we are going to see headache like tension type. कहते हैं ना कि टेंशन हो गया है, हेडेक हो रहा है, छोड़ दो मुझे. So this is a tension type. So we are not like see, till now you were thinking tension is a normal thing. Now you understood like no, tension is so important. So okay, okay, I hope everyone is able to see the screen. So like the most common, I would write commonest type of headache, right? So who gets more headache, male or female? It's female. 90% normally in their lifetime, but data says male get 70%. Okay, so what is the characteristic feature? Characteristics, remember the word: diffuse, dull, bend like, aching. Will you remember these words: diffuse, dull, bend like, aching, headache? Okay, okay, as you know, you'll be taking your history, and also like normally the person will say that uh, you will find that it is associated with some tension or any physical discomfort also could be there. Physical discomfort. Okay. No, it could be acute. No, I sorry. It could be chronic because it is not a one day story. So it could be chronic, and obviously, at times it can come. No particular pattern, but they will pattern varies from person to person. So when it comes, how long it stays? Hours to days, few days. When it comes, it stays. ओके, तब वो लगाते हैं ना क्या क्या, वो ऑयल, नवरत्न तेल और पता नहीं क्या क्या लगाते हैं. Somebody takes sari down or all those things. I'm really, I mean, navratna tel is okay, but what is there to take tablet for headache? But there are people. Okay, any other characteristic you have seen? Normally people will be depressed, so depression is one of, also you can say that, common feature. Okay, so if I ask you frequency, how frequent person get it, then you cannot predict it properly, but most of the time it could be daily, many a times, sorry, many a times it could be daily, or toward um, evening, toward evening. Okay, if I talk to mechanism, how it happened, mechanism is not fully understood in general, but tension type headache has been seen with anger, clenching teeth. Okay, clenching teeth, and just a minute, clenching teeth, or it could be some cervical issue, cervical, I would say that, muscular issue. Okay, exactly, cervicogenic headache, what I'm saying you, that also could be related to the tension type headache. Yes. So what is the treatment? Sorry, done. Okay. No, no, I'm not saying that. Reassurance that it will not happen again. You have to have a proper counseling. Okay. And reduce painkillers. Definitely reduce painkillers. Reduce even the stress, whichever is running in the life, if you have to. If not, then if you are going for the medicine, then beta blockers, or if patient is having more depression, then antidepressant. Okay, why did I make this picture? Just to make you understand that headache will be in this band, इधर ही होगा, एकदम सामने, हेड के सामने, फोरहेड पे, फोरहेड वाले एरिया में. ओके, yeah, I'm not saying only this, but yeah, I mean, this is the most common area. हाँ, ओके, यहाँ पे एरिया में, ठीक है ना। सो दिस इज टेंशन टाइप हेडेक फॉर यू, वेरी सिंपल। Next, we will see is what is migraine. Have you seen the case of migraine? It's also one of the common. I would say the second most common. What we were studying, right? We were studying, right? Second most common. Well, so uh, I would say that it is a common. If first point you have to write a definition only, right? Migraine is a common pain characterized by, choose your word very carefully and, if possible, just mug up my word. Characterized by uni, unilateral throbbing headache. Okay, remember this word, unilateral throbbing headache. You ask person having headache, they'll tell you the same thing. Unilateral throbbing headache. Okay. So if I talk about onset, it could be childhood or young age, early adult, early adulthood. Okay. Okay, more into male or female, more into female, and I would say that ratio is 2 is to 1. Okay, family history is there or no? 70% cases it is seen. If I talk about incidence, how common it is, as you know, it's a second most important kind of headache. So up to 10% of population, so say for example, depends upon the race, 5 to 10% of the population. However, I'm teaching you here migraine in a normal what I studied, okay, but there are a lot of things, a lot of improvements in migraine disease, and then we have a different kind of like a different way of studying migraine, different way of knowing the migraine. Okay, so like in general, if you talk about that diagnostic criteria, so there are two types of migraine normally, two forms basically. And migraine they ask, so remember that two forms usually, that is like common. One is migraine with aura, another is migraine without aura. Okay, what is aura? Aura is a different like a very strange term. Okay, first let us understand here, then I'll come in that. Migraine without aura, this is more common, remember that. Okay, if you write your answer like this, it's always good. Okay, so aura is basically is a very strange word, but for you, you understand it's a warning of kind of warning type of stuff, especially for the warning of visual or motor type or sensory, then followed by headache. Okay, headache will be again throbbing, unilateral, more light will increase. Okay, so it's a kind of aura, like indication is there. So it's a warning of motor, sensory, you know all these, like or it could be visual also. But person will know that it's going to happen. Okay, then it will be headache will come, followed by headache, followed by headache. Okay, so again, what kind of headache it will be? Unilateral throbbing headache. Okay, throbbing headache. So whenever the patient takes rest, sleep, it reduces. Okay, very rarely, not rarely, I would say occasionally there is a chance of vomiting also. Okay, so this is the story of with aura. But without aura, there is no warning. Okay, headache will be like this only: unilateral throbbing headache. Unilateral throbbing headache, this is the common feature. Okay, but there is no warning that it is coming, and you can't even localize. So you can say that it is poorly localized. Okay, poorly localized. And many a times, like they'll tell like it's like a tension type headache. So it will start at one part of the brain, but they are not able to localize. Okay, got my point? Yeah. So this is how two forms you should see the migraine. One is with aura. Aura is nothing, just think as a warning. Okay, and that is without aura. Without aura is normally more common. Okay, it both will have unilateral throbbing pain only, but one will have some warning of motor, sensory, or kind of visual issue. But normally for migraine without aura, there is no warning, it will come. Okay, the question is like what kind of aura? Okay, well, aura could be visual, as I told you. It could be, like disco lights. You have seen that disco lights, what we say as a kind of flashing lights, basically flashing lights. Then fortifications. Then it could be central vision, we say that, scintillating scotoma. These all visual defects can cause it, no doubt. Okay, some like central vision, this can cause, no doubt. So which type of headache again? Headache will be recurrent headache normally, which will go from 2 to, I will write just a minute. Duration part I'm writing: recurrent headache, which will start and it can be 2 hours to 2 days also. I've seen multiple cases. 2 days. Okay, if you ask me like how frequent it is, frequency 2 times per week, or 1 to 2 times per week. Okay, yeah. So this is how a normal general feature of migraine. Okay, now we will see the, just a minute. So next we are going to see that, like a mechanism. Okay, one or two words you should remember in the mechanism. So what is the mechanism basically? Mechanism, how it starts and how it happens. So you can just remember, if since it is a genetic, so genetic cases, like in cases when it is genetic, it is found familial, you can, what you can say that it's a mutation in DNA and calcium channels. Okay, so serotonin activity which get disturbed, okay, in either vascular or neuronal, both. Okay, vascular and neuronal both process, which normally happens together with changes in serotonin activity. Okay, this much you can remember, enough, actually speaking, enough. Okay, now with aura, let us have like some types. What we know, types of migraine. With aura, ठीक है. So remember, bacillar, first type, then hemiplegic, then ophthalmoplegic, then related to eyes. So I would say that here is retinal. Okay, so bacillar, it is usually like a bilateral visual symptoms. Okay, so in bacillar, what happened basically, it's a bilateral visual symptoms. ठीक है. Dysarthria, if you remember, this much is enough, actually speaking. Types is more than enough. Dysarthria, not, patient is not stable, vertigo, all these things happen. Bacillar, weakness in the limb, abnormal sensation in the limb, paresthesia in limb, okay, etc. Mostly in the young girl. Okay, they feel like they are getting unconscious, so it's more in young girls. Okay, hemiplegic. Hemiplegic, it like it will be characterized by an aura of unilateral paralysis, and this will like an aura of unilateral paralysis. It will continue after like after the headache has settled. Even the headache is gone, it will be continue. for 3 to 7 days. 1 week after headache subside. Okay. Ophthalmoplegic. It is characterized by what, extraocular nerve palsies. Extraocular nerve palsy. Cranial nerve number 3. And no, 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 no. There's a question that, after hemiplegia, will that happen? The hemiplegic? No, no. This is a type of aura. Try to understand, student. It's a type of aura. Aura of unilateral paralysis. Usually, after the headache goes, after 1 week, also patient feels it. It is not a paraplegia. I mean hemiplegia. No, no, not at all. Don't get misdiagnosed. Yes. So usually, what happen? Extraocular nerve palsy, like number third. Okay. Sometimes even the sixth also. Okay, since it is related to eyes, so even sixth. But how it results from? It results from dilatation of internal carotid artery. So it stretches the third nerve or even sixth nerve within the, tell me the very important organ there where the third cranial nerve passes. In fact, most of the cranial nerve passes. Cavernous sinus. Very good. Cavernous sinus. I think you were in the, you have seen my anatomy class. Cavernous sinus, correct. We're talking about the vibration and all, right? In first name. Wonderful, wonderful. I remember. I remember your name. Screen name, in fact. Okay, good. Okay. So anything else? Retinal. Okay. What about retinal? It could be monocular. uh It could be monocular. It's monocular. Visual loss. But get back. So it's a reversible followed by migraine. That is the headache. Okay, so these are the types, these are the presentations. One more is very very like rare, but it could be present. I don't know whether you know about it. Have you heard it? I didn't like to scare you in general, but very rare migraine coma. For your knowledge, I'm telling you, migraine coma. Okay, what happens in this? It can present as an episodic coma. Migraine can manifest as an episodic coma. That's it. Yeah, migraine coma. No, I just remembered, so I told you. Okay. So, what is the precipitating factor? After the types of migraine, we are going to, just a minute. Yeah. What is the precipitating factor? Tell me. I was talking to one of my junior. Then I was asking few days before about the precipitating factors, how it happens to you. Few people will tell that if they take amla or if they take guava, it happens with them, or if they take any kind of sour fruits, that happens. So obviously, dietary, very important, dietary part. Okay. importantly alcohol or chocolate, specific type of few chocolates or cheese item. But I have seen even the people having dosa early morning, few of them they have seen that they can manifest migraine kind of symptoms. Okay, cheese. So basically cheese is a very good thing, but in general, so anybody can tell me what is in the cheese, which amino acid is in cheese? Tell anyone which can cause it. Paramine. Okay, this is the chemical. Well, another thing could be hormonal, very important. So premenstrual, they exhibit the symptom. Okay, premenstrual. Then definitely any kind of hormone, if it is up and down in estrogen, okay, it can give, or oral contraceptives can, oral contraceptive usage also has been found with that. Okay, so fluctuations in hormone, as I told you, estrogen fluctuation. Okay, yeah, anything else? Definitely. Wonderful. Stress, can never ignore. Even exercise, lack of sleep, head trauma. So these all are precipitating factors. Okay. So after that, diagnosis, obviously. Diagnosis. What can you do in the diagnosis? Obviously, you'll be matching the history, clinical history. You have to ask clinical history, like it could be family history of disease, or you have to ask, we say that migraine variants, abdominal pain in childhood. So basically you remember travel, sickness. Okay, few child will have that in childhood. Okay, when was the onset? Childhood or early adult life or adolescence. Okay, or menopause. Okay, all these things. Then you should have a distinguished feature also. I would say that distinguished, like you have to do the distinction, like focal epilepsy. In hemisensory migraine it can be caused, like a hemiplegic migraine it can be there, that kind of thing. Or arteriovenous malformation, I think you would have heard it. Okay, it's a well localized, but it's a chronic backache, sorry, chronic headache basically. So, and then obviously lack of glucose, where the person can have fall, hypoglycemia. That also could be the reason. Alexa, stop. That could be the reason. So when we come to our, headache, sorry, headache management. What are we going to do here? First of all, whichever is causing, you have to avoid. Say avoid avoidance after identifying precipitating factor. Right? Best treatment part starts from here. First of all, which is causing, identify, and don't count on that. Well, then for frequent and severe attacks, you can have a, like a, we say that prevention, so prophylaxis. Not for all the case. Some prophylactic medicines you can have, like propanolol. Okay, so this is beta adrenergic receptor blocker. Okay, propranolol, or maybe some 5s to receptor blocker. We say that methylsargite. Methylsargite. Okay, yeah. Then how you have to prevent the acute attack? You can't actually. I mean, I'm talking about how are you going to do with the acute attack? What are you going to give them? Analgesic. You can start with the aspirin. Okay, obviously not good for long run. So usually aspirin with with metoclopramide. Okay, so it will reduce the absorption in the attack. Okay, well, this should be okay. I don't want to give you more medicine name. Sumatriptan, you know, one more you can remember. Sumatriptan. What is this basically? Sumatriptan, anybody has any idea? It's a 5-HT1 antagonist. Enough for you. Okay, this is enough for you. So another few minutes will go. Yeah, somebody was asking that time. Cluster headache. What is cluster headache? Huh? Well, it is like a migraine only, but it happens like it's lesser than migraine, no doubt, but it happens more in male, more in 1 minute, 1 minute, 1 minute. It happens more in male than the female. Okay, okay. So what is characteristic? See, 3 marks question. Characteristics: several unilateral pain around one eye. Okay, around one eye. Okay, and this will be, associated with, associated with, yes, yes, conjunctivitis, basically eye infection. Okay, or more, like a nasal discharge will go. What do you say that? More nasal discharge, what you say that? Rhino, rhea, or more tear, somebody having more tear, lacrimation. Even in the Horner syndrome that happens. Anyway, just you remember this much. Okay. Duration, when it come, till when it remains. Duration, it can go in 10 minutes to maximum 2 hours. Okay. Frequency, how frequent it is. But how frequent it is? It could come one, two, many times per day. Forget about week, I'm not talking only. And you have to write this: patient get awake from sleep. This is the irritating part of this. Precipitating factor. Precipitating factors. Alcohol. Okay. Okay, what is mechanism? You tell me what is mechanism. What do you understand? Normally, this kind of headache, you know, serum histamine level rises. No, no, here will not consider stress as a factor. So serum histamine level rises during this pain, especially during this attack. Okay, so it is also called histamine cephalgia. What is treatment? Finally, students, just let me know whether you have been asked question on like temporal arteritis. Any question till now, past 5 years? Then I'll go. Otherwise, I will not go with like all those treatment of this antihistamines. No, if it is histamine, antihistamine will not all the time work. Anything else? Remember this drug. Problem with this drug is, remember the drug combination: ergotamine plus suma. Just now we understood, right? Suma triptan. So this will be good. If not, then even the steroid, prednisolone, 30 mg in refractory cases, and that's all. You remember this much enough. Okay. You have been asked questions on this giant cell arteritis. Anybody? So okay. Okay. Other types of headache. Okay, let us discuss 2 3 points about it. Okay, post traumatic headache. Post traumatic headache, it is like a normally it is a kind of, like a kind of migraine or tension type headache, usually arises after the head injury, and it will have other symptoms like, lightheadedness, irritability, difficulty in focus with the work. Yeah. No, it is not like that. It is having a organic base, so you cannot say that all the time it's a psychological. No, not really. But after headache, like after trauma, yes, amnesia results in some neuronal damage, and it can cause some, like a evoked responses abnormalities. That's where the post-traumatic headache has been there. So you are not asked giant cell arteritis. Treatment you can do like as you are doing for tension type headache. Nothing very special here. Okay, I'm writing it. Giant cell, it is also called temporal arteritis. Yeah. So it is an autoimmune disorder. Yes, 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 definitely. But it is an autoimmune disorder disease, unknown causes. So we don't know what is the real cause of this disease. Normally in elder individual and the elder population, it is more common. Okay, it's a severe throbbing in nature. Okay, and it actually overlies in uh, the particular vessel wherever it is starting, like that. uh, it is involved there itself. So what is that? Mostly it is a superficial temporal artery. That's the reason it is called temporal arteritis. Okay. So when you palpate, it is thickened, tender, but non-pulsatile artery. Okay, not able to see on camera. This side. Okay, non-pulsatile. Okay, so symptoms like it could be hemiplegia, it could be hearing loss, it could be myelopathy, it could be even neuropathy. Normally, weight loss, general muscle pain, in older individual this can happen. Muscle pain in general, I'm telling you. Okay, it is intractable. So like when you start the treatment, headache will go, like that it is. Yes, yes, there is a mechanism. There is a mechanism that, these most of the medium and large size arteries that will usually, undergo intense giant cell infiltration. That's where the lamina get disintegrated, and then lumen get, like a narrow. So ischemia can result. You have seen in second year, right? I mean pathology. So pen sensitive fibers, it can get stimulated. So occlusion of these, like arteries, basically the ophthalmic artery, it may result in even blindness. Yes, because it's ophthalmic artery I'm talking about. If it is a basilar artery, that can cause brainstem. infarction. Okay. Yeah. So usually, as I told you, it is related to blood, so ESR will be higher in diagnosis. Then you have to go for even the blood film, blood test also. C reactive protein, very important, because there is a clear, like a talk about the disintegration of arteries. Sorry, there is a talk of fragmentation of arteries, so you have to go for C reactive protein. Then ALP, hepatic ALP, alkaline phosphatase, that will be higher. In case even the biopsy required, 1 cm length of temporal artery, that will be taken for the biopsy. Treatment, obviously, urgent treatment required. So steroid, prednisolone, again. So that prevents the visual loss and brainstem stroke. It will relieve even the headache. No, if blindness has happened, then definitely this has to, like high dose steroid. It has to go for, yes. And steroid, how it works. First you have to give, then it is a withdrawal dose. So let's leave that thing on our medical. Yeah. Third one, other types of headache, mate. Headache due to raised intracranial pressure. So when we come into that chapter, we will study. Okay, it is a generalized headache aggravated by normally coughing or even bending forward. Like normally it is worse in the morning, and it can also rise, like it can awake patient from sleep. So and it gradually it increases. Okay, so normally in later vomiting also starts. Then there is a loss of vision also marginally. Obviously investigations are required is CT and MRI. And then obviously when we read about the raised intracranial pressure, we'll see more into that. But that's why headache is caused by the raised intracranial pressure as well. Yes. So low pressure headache also, yes. Yes, yes, yes. So normally post lumbar puncture headache also has been seen. Okay, obvious or occult, like what we say, cerebrospinal fluid get leak. So posturally dependent, worse when erect, and normally if patient is lying down, it becomes better. Okay, yes. And then after that, what we were talking about, head injury, right? So headache due to intracranial damage, sorry, intracranial hemorrhage, blood loss. Okay, so it will obviously, as I'm saying you, hemorrhage, that means instantaneous onset head injury, severe pain. It could be like right from the top to occiput. It will be painful. Patient may fall unconscious. Okay, it can have a vomiting as well. And then obviously wherever there is a hit, the focal neurological symptoms will come. That says the hematoma again, right? So CT, immediate CT, and then lumbar puncture just to rule out the meningism. Okay, yeah. Other things like non neurological causes, non neurological causes, what all can be? Yes, very good. भूले नहीं हो. Sinuses, huh? Good, very nice. Sinuses, then ocular This only will work better for you. If anybody knowing basics, it can never be a problem. Good. Very nice. Keep it up. Ocular. Yeah, obviously. Again, it can be refractive disorder, glaucoma, or it could be even the ciliary issue also. Yes. And then obviously tooth. So what we will say is dental issues that we have to leave on dentist. Yeah. Okay. Then headache of. Okay, I think other types we have covered almost all. Just a minute. Yes, yes. Fever and infection. So we will write systemic conditions, systemic disease. So with this, we are covering complete headache. Okay. What we started from the general principles. Okay. General principle of headache, like we defined headache as a pain and discomfort, obviously, between the orbit and occiput, arising out of pain sensitive areas. Then we divided pain sensitive areas in intracranial and extracranial. Then we went for like classification of headache, where we found the tension type headache and migraine having the major percentage. Then we went into diagnostic approach with history in our examination. Then we went for uh, categories based on the based on the categories, like we saw causes, basically causes, and then categories. So acute, subacute, and chronic. Yes. Then we saw, like a specific kind of headache, like headache tension type headache. I should write it, tension type headache, otherwise give a problem. Headache, okay, where we found the 90% in female, 70% in male population normally, and is most commonest type of headache, diffuse, dull, band like, aching. You should remember that. Then we learnt about migraine, okay, having two forms, with aura, without aura. Aura means kind of warning, okay, it could be visual, sensory, motor. Then we found the types of migraine with aura, like basilar, hemiplegic, ophthalmoplegic, retinal. Very rarely migraine coma as well. We saw the precipitating factor, especially where the dietaries are very important. Then we saw about the diagnosis. We saw about the management of the migraine. Then we saw about the cluster headache. Okay. Then we saw about the cluster headache is where like the male has more incidence than female. Then other type of headache, like post-traumatic headache, we spoke something. We discussed about uh, giant cell temporal arteritis, okay, which is actually the autoimmune disorder, especially in the elder population. Okay, supratemporal artery is something which is into trouble. And then we saw the headache due to raised intracranial pressure. And I hope you all remember intracranial pressure very well, what we studied some time back, I think 2 weeks before. Okay. Oh, actually, not for this batch. Okay, no problem. We studied about CSF. No problem. Headache due to intracranial, again, hemorrhage. Okay, that's very important. More of brain injury. Non-neuronal, and most of the time it's emergency. Then we saw about the non-neurological causes also. That's always like, more commonly like sinuses, then ocular, then dental issues. Then we saw about some systemic issues also we discussed like earlier. So with this, we finish the headache chapter. Okay. And I hope you all have understood this properly, and I hope you all are revising these chapters really well.